Finally, Sneddon's syndrome and libido. Sneddon's syndrome, I guess there's this overlap. I'm not quite sure what's what, but Sneddon's syndrome is stroke with libido reticularis, and there are two descriptions of libido, racemosa and reticularis. So I might just touch briefly on a case. I'm mindful of the time. Yep, I've got time. So this was a 42-year-old Caucasian female, an accountant who owned a business, very successful. And she was 8 years with the mental health service. An initial diagnosis was anxiety disorder. She'd seen several neurologists and psychiatrists and was diagnosed later as a conversion disorder because she actually had weakness but did not fit any particular pattern. It was on and off. She would come in with a limp and would have extreme pain on occasions as well. She had a number of other symptoms: confusion, complained of jerky movements of both upper limbs, described them as seizures, gait abnormalities, a stepping gait, slowed movements, severe headaches, previously described migraines, bladder incontinence, right-sided weakness of both upper and lower limbs, severe aching pain in her legs, frontal lobe executive dysfunctioning through luria, and she described a malar rash, although it wasn't seen when I'd seen her. But one of the interesting questions that when I went through the history was, she said, my mom's diagnosed with lupus, so, red signal there. So I carried out for lupus anticoagulant, anticardiolipin, and beta-2 GPI. And this was her lupus anticoagulant testing. So this was a kaolin clotting time, delta KCT, Russell Viper venom, all of them elevated, clearly showing that there was an abnormality there. Her MRI actually showed white matter, just two white matter hyperintensities. The other one is here. But I then gave her information to read about antiphospholipid syndrome. And she came to me and said, Sanil, I need to show you something. And this was in the room. She said, I need to take my trousers off. Called in a chaperone. And she said, I've had this for 8 years. It was extensive everywhere. And I think that was quite a prominent sign. Having said that, she had a very good response to she was put on aspirin, continued symptoms, but it was very difficult to move forward. And I think some of the things that was mentioned in terms of actually getting further anticoagulation treatment. The hematologist, having said that, did take her on. But she was put on aspirin, but none of the other aspects were tried. She continued to have these symptoms on and off, so there wasn't a very good response with aspirin. The other one is a very interesting case that I'd seen. This was a consumer consultant. 48-year-old female was diagnosed with bipolar disorder. But I went through her case files. I saw her when she was 48, but I went through her case files, and her first presentation was when she was 14 or 16. And she was admitted with severe psychosis and, on occasions, catatonia. And she, for 10 years, received repeated ECTs for several years with lithium. And around the age of about 25 to 30, this subsided. And this is something that's kind of linked when we look at the article by Kapadia and Sakic in 2013. They describe two phases: the initial phase of neuroinflammation, followed by neurodegeneration. So the question is whether there is that initial inflammation that results in acute symptoms, which is then followed by neurodegeneration, cognitive issues. So we're not quite sure. But in her case, she then around the age of 40, so she had on and off symptoms, no major, had 2 children, no major acute episodes as such, was in the outpatient throughout. Around the age of 40, she met a friend who told her that she was diagnosed with lupus. And when they discussed, she went through a number of criteria. And she said, I'm experiencing the same thing. So she went to the GP and said, can I please be tested for lupus? And this was these were some of the actual symptoms that she had when I had seen her. As I mentioned, a history of catatonia. But around the age, she actually had positive ANA. She then had dsDNA positive as well, and I'll show you the titers. But around the age of 45, she developed a femoral artery embolism. And that's when the anticardiolipin testing was done. and she was since then on warfarin. And she told me that she used NSAIDs to help control her mood. Anecdotal, but it was an interesting observation that she mentioned. She would take Brufen. She would take Nurofen or Brufen, I should say, for ibuprofen. And she had a history of aortic stenosis as well, diagnosed 6 years ago, so heart involvement. And this was her examination, her nails on examination, so you could see nail bed vasculitis. But what was interesting here is, because rheumatologists, well, some of the rheumatologists I've come across often say the ANA is not high enough. But this lady, I went through her notes extensively from the past, and her ANA was consistently 1:80. But her DNA kept rising, and it was 133. And there's some evidence that dsDNA is highly correlated with renal involvement and something along those lines. So I'm not sure. While the P-ANCA was positive as well, and anti-cardiolipin antibody was positive. But what was interesting is 11 years ago, I went through her blood tests, and these were actually positive 11 years ago. So the question was, when do we treat it? When should she have been treated? But the larger question is, was a psychiatric presentation many years ago related to this? But I still carried out an EEG, because the question is, we know in lupus and anticardiolipin syndrome or antiphospholipid syndrome, the symptoms of mood disorder may be related to the seizures. So her EEG actually, as you can see, shows sharp spike and wave discharges. So it was actually most likely the mood symptoms due to seizures. So she was additionally started on valproate along with her carbamazepine as well. And her MRI showed multiple deep white matter punctate lesions here. So, I mean, it's an interesting case. And this was a young girl, the one I mentioned, with psychosis, diagnosed with schizophrenia, but atypical. Even on her notes, it was atypical psychosis. She was complaining of severe migraines, and she was, I think, 22, and terrible frontal lobe executive functioning. I mean, out of proportion to any depression or psychosis. And I asked her, is there anything, any rashes on your body at all? And she showed me this, libido. She was the one that had seizures a few months later. But the aspect here was also, she said that she was sitting close to a heater, because the other differential diagnosis is erythema ab igni. But it wasn't there on the other side, even though she was sitting to the heater. So I don't know what it is, but it was an interesting observation. This is another young girl I saw who responded very well to aspirin. She had extensive libido. This was last summer, actually, and she had seen 19 different doctors. But I remember it was very striking looking at this and saying, how long have you had that? Does it ever go away? And her father also has extensive libido. She had a very, very good response with memory improvement, and the psychologist came and said she's doing so much better as well. And her migraines reduced in frequency and intensity significantly. This was actually an anecdotal conversation when an email that Professor Hughes had sent me, which I think you just covered earlier, and the heparin as well. This was in the article, word finding score dropped from 15 to 95%. So the pathogenesis, if I just briefly through the APS pathogenesis, what's been described is there are two hits, that the first hit might not be enough. The first hit could be infections, smoking's been mentioned, several other things that Professor Hughes might talk about this later on. But there seems to be a need for a second hit that then results in the formation of these beta-2 GPI complexes. And what's been described is normally the beta-2 GPI is in a circular form. But when there is this second hit, it actually changes form and becomes a sort of hook-shaped, which exposes these immunogenic epitopes which have previously been hidden. And that's why these antibodies to APL start getting produced. Once that happens, some of the things that have been described are looking at, I'll just go back, the binding of the antiphospholipid antibodies to endothelial cells and platelets. But the other aspect is interference with the coagulation cascade. The other three mechanisms are, I mentioned, inhibition of anticoagulation reactions, cell-mediated events, and neural events. I guess this is a part of, a draft at this point in time that I'm collaborating with Dr. Charles Mackworth, young rheumatologist in the UK, and I've sort of run this by Professor Hughes as well before. So it's sort of a work in progress, but yeah, I'd be interested in your feedback. These were some of the newspaper articles that have been published about Hughes syndrome. This is an interesting case, actually, in the Journal of Rheumatology, where, again, a number of symptoms that we talked about, sudden hearing loss, severe headaches, responding very well to aspirin, and the recommendations that aspirin is a diagnostic challenge, which is what I used in the previous skill, just as a diagnostic challenge for about 2 months to see if there's improvement. I mean, there's always the possibility of a placebo effect, but if the patient gets better, I think I'll take the placebo effect. The other aspect is the Professor Hughes August blog, the Patient of the Month. I've got a lot of guidance through that. A number of patients actually have psychiatric symptoms. And the bigger question, is Hughes syndrome the new syphilis? Interestingly, it had a false positive syphilis test as well. So this was in the Daily Telegraph. There's a book on case studies for patients. A number of them have psychiatric disorders as well. So at this point in time, when to suspect antiphospholipid syndrome, some of the things that have already been mentioned: atypical psychiatric presentation, treatment resistance, migraine, cognitive dysfunction, stroke or TIA in patients less than 50 years, diagnosis of SLE, recurrent miscarriages. So I think some of the things that have been discussed, many of them have just been sort of put together, but this may get refined over time. So the conclusions really, what's interesting when I look at the reviews in terms of medications, aspirin, omega-3, and statins are 3 evidence-based treatments that have shown to be of benefit in both psychiatric disorders and thrombotic illnesses, and may be beneficial in psychiatric disorders with antiphospholipid antibodies. So the question is, are they biomarkers? Could antiphospholipid antibodies be biomarkers telling us we need a different kind of treatment? So an etiological role hasn't directly been proven, but it's highly likely. Now, I think, let me just have a quick look at the time. Yep. We see, in psychiatry, we see individuals with stress and trauma. And is there a link between trauma, stress, and the immune system? There is a very clear link. So this is the diagram that we've published in the journal that should be out in January, hopefully. But what the key point I'd like to bring your attention to is that it interferes with cortisol pathways and the cytokine release. But what happens is, because there's chronic stress, it results in a downregulation of the glucocorticoid receptors in the T lymphocytes. So there isn't an inhibitory signal at all, which exacerbates the whole immune response. So really it's the link here, which results in a prolonged inflammatory action that can then result in autoimmunity, passage across the blood-brain barrier, and all of these things. So are psychiatric disorders manifestations of autoimmunity? A subset, a very high biological plausibility is present. And I'd like to bring your attention to evidence in borderline personality disorder. This was an EEG study done in neurology for borderline personality disorder. 40 to 84% of patients with borderline personality disorder have slowing of background activity. And I see that a lot in clinical practice. Slowing usually indicates some structural involvement. There has been the possibility of TPOA-AB antibodies in borderline personality disorders that have come up as well, and polycystic ovarian syndrome, which is an inflammatory disorder. These genes are actually in SLE, and as you can see, this is in schizophrenia, bipolar, and neuroreglin, as we know in schizophrenia as well. Commonality is present between both. So genetically, and the other one is post-traumatic stress disorder and the use of low-dose cortisol as well. So future research should include autoantibodies, and inflammatory markers was one of the aspects we did put in, and Kapoor has mentioned that earlier. Multi-specialty collaboration, I think, is really, really important, cross-specialty collaboration. And we must pay special attention to the milder, incomplete cases, not only of anti-NMDA encephalitis, but I think SLE as well, NPSLE. And we may have a range of other medications in the future, N-acetylcysteine, coenzyme Q10, lipoic acid, curcuma, recent trials being done there. So there's, I think, a lot of other aspects that might come out in the future. I think the broad question is a medical evaluation important? I think extremely important. I'll point to this statement. This was a review of 21 studies done in psychiatric patients. Approximately half of the patients suffered from significant physical illnesses. Of these, 58.2% were previously undiagnosed. A substantial proportion of the physical illnesses, 27.1%, produce symptoms showing direct relation to the psychopathology. So it's quite a lot, 3 out of 10, which is a significant number. Finally, towards the end, I'll leave you with 3 quotes, which I quite like, and one coming from a neurologist. The psychiatrist must first and foremost and all the time be a physician. In fact, psychiatry is neurology without the physical science and calls for diagnostic virtuosity of the highest order. The psychiatrist should not only first be a physician, but ideally a superlative physician. It's quite nice coming from a neurologist, I think. And of course, Osler's quotes. So several acknowledgements. I've put in a number of references which you have, which I think will be quite helpful. And this is the article that is available online, Immune Dysregulation and Autoimmunities. Much of what I've covered is available to view already. And finally, thank you, and any questions.